Oh, there we are. Can you hear me and see me?
Yes.
Yep.
Awesome. First, any questions or concerns?
Do we have class next Tuesday?
We have class next Tuesday, but we don't have class on Thursday.
Okay.
Yep. Other questions? Okay. So what I want to do today is go through the lab exercises. If you looked at the syllabus last week, we were supposed to go over the lab exercise 20 and 21. I'm changing that. I think there's a lot just for the lab exercise of 20 by itself. And I didn't want to do them together. But you'll see that today's lab is fairly short. There's two things I would like to do afterwards. And one of them is I have a sheep brain that I'd like to dissect. And then let's see how much time we have after that. And if we have time, I'd like to continue lecture for a little bit, but let's just see what happens. So we started at the very end of the lecture, we started talking about the cranial nerves. And you know what? Why don't I finish that first? Because one thing about the cranial nerves is repetition is never a bad thing. Repetition is, with regards to anything, is never a bad thing, but especially with the cranial nerves. So let's finish that. We only had like 5 slides left. Give me 1 second here. So right here, cranial nerve number 12, cranial nerve number 11 controls swallowing, head and neck and shoulder movement, and damage to it can cause impaired head and neck shoulder movement and cause the head to automatically move to the injured side. So you have it on both sides of your neck. And if it's injured on your left side, you're going to automatically, when in a relaxed state, move your head to the left side. Remember, this is the one that I've mentioned a couple times. Technically, it's partly a cranial nerve, partly it's not. Because if you remember, by definition, all of the cranial nerves come off the brain and the brainstem. This one has two roots. One comes off the brainstem, right here, the medulla oblongata, and one of them comes off the cervical spinal nerves. About 20 years ago, we've always assumed it was a spinal nerve because of this root right here. I'm sorry, a cranial nerve because of this root right here. And about 20 years ago, there was a paper published indicating that technically it's not. It's somewhere in the middle. And so we still consider it part of the spinal nerve, the cranial nerves, but it also has a root coming off the spinal nerves, which means that it's somewhere in the middle. So it has a double origin. One origin coming off the medulla oblongata, one coming off the spinal part of the cervical nerves. It's specifically motor in that it's going to innervate the sternocleidomastoid and the trapezius muscle, which we will talk about. One of the last labs we do is specifically what those muscles are and where they're located. I told you I'm trying this semester, I'm trying to introduce some cadaver photos into my thing because I don't think that your diagrams always do things a lot of justice. So if we look here, and it's kind of a dark picture, but here's the medulla oblongata. Here's the root coming off the medulla oblongata, the brainstem. And here are the roots coming off the cervical spinal cord. Any questions so far? The last cranial nerve, the hypoglossal nerve, controls tongue movements involved in speech, food manipulation, and swallowing. It also has a role in taste. Very minor role in taste. Actually, wait, you know what? I'm wrong. Let me think about it. It's only motor. One thing that we didn't mention before is the vagus nerve is also involved in taste. We don't see that here. See major role in control of cardiac, digestive, and urinary function. Well, part of digestive function is your mouth. So it plays a role in taste also. One of your questions in your case study asks you which three cranial nerves are involved in taste. The vagus nerve is one of those. So the hypoglossal nerve is only motor, and it's controlling the muscles of the tongue. So muscles of the tongue. If damaged, one cannot protrude your tongue. if one side is damaged, the tongue will deviate toward the injured side. And then there's this ipsilateral, meaning atrophy of that one side of the muscles. When a nerve fails or starts becoming defective or damaged, all of the muscles that it innervates are going to undergo atrophy. So when a cranial nerve gets damaged, like what we saw up here with the spinal accessory nerve, when it gets damaged, the sternocleidomastoid on the damaged side and the trapezius muscle on the damaged side are both going to atrophy. And the head's going to lean towards that side. Same thing for the tongue here. All of the tongue muscles that are innervated by one hypoglossal. Glossal means tongue, hypo meaning underneath. So the nerve underneath the tongue, here's the tongue right here. Overview. Remember that just as a summary, cranial nerves can be completely sensory, completely motor, or they can be mixed and be both sensory and motor. Looking at this, it tells you the red lines are motor, the green lines are sensory. So sensory meaning the information is coming in, motor meaning the information is going out. Questions for me? So I want to go over this PowerPoint that I set up for lab. So lab exercise 21 was the cranial nerves. And like I mentioned the other day, the cranial nerves are numbered according to where they come off the brain and brainstem. Technically, they're all coming off the brainstem. But looking at the picture, some of them look like they're maybe coming off the anterior surface of the brain. And that's not correct, but it looks that way. So technically, they're all coming off the brainstem. But just because of appearances wise, we say it's coming off the brain and the brainstem. So going down, the olfactory nerve, cranial nerve number 1, the optic nerve, cranial nerve number 2, the oculomotor nerve, cranial nerve number 3, the trochlear nerve, cranial nerve number 4, the trigeminal nerve, cranial nerve number 5, the abducens nerve, cranial nerve number 6, the facial nerve, cranial nerve number 7, the vestibulocochlear nerve, cranial nerve number 8. Cranial nerve number 9 is glossopharyngeal nerve. Remember that glosso means tongue, pharyngeal meaning your pharynx. Vagus, cranial nerve number 10. Hypoglossal nerve, cranial nerve number 12. Remember that they kind of switch places. Here's cranial nerve number 11. Here's cranial nerve number 12. Any questions? So I told you the mnemonic that I like, because I'm a Harry Potter fan, is on, they traveled and found Voldemort guarding very ancient Horcruxes. However, if you go into, if you Google mnemonics for cranial nerves, you will find 4,000 cranial nerves. Here are a bunch of them. To touch and feel very green vegetables, such heaven. To take a family vacation, go Vegas after hours. So find a mnemonic that works for you and remember them in their order. To touch and feel a great vampire and shoot him. Oh, that's funny. All right. So use whatever works for you. You also want to remember whether it's sensory, motor, or both. Some say money. Let me go back to the figure. Some say so both of these are sensory. Money matters, both of these are motor, but trigeminal is both. My motor, abducens nerve. Big facial is both. Brother, cochlear is both. Says, glossopharyngeal. Actually, why am I off? I know I'm off. Okay. Some say money matters, but my big brother says big bucks matter more. So you want to remember sensory, whether it's sensory, motor, or both. And I'm looking from this picture. This obviously is a picture. And we're looking at the cadaver. And depending on what cadaver you get, they can look slightly different. That's why usually when you're learning anatomy on a cadaver, you look at multiple cadavers. But here's the olfactory cranial nerve number 1, cranial nerve number 2, the optic nerve, cranial nerve number 3, the oculomotor nerve, cranial nerve number 4, the trochlear nerve, cranial nerve number 5, the trigeminal nerve, which has 3 branches, which we'll talk about in a moment here. Let's see, 5, 4, 6, cranial nerve number 6, abducens nerve, cranial nerve number 7, the facial nerve, cranial nerve number 8, the vestibuloacoustic or cochlear, acoustic meaning sound, cochlear is the hearing organ, so they can call it the vestibuloacoustic or vestibulocochlear nerve, they're the same thing. Glossopharyngeal, cranial nerve number 9, cranial nerve number 10 here is the vagus nerve, cranial nerve number 11 is the spinal accessory or accessory nerve, and cranial nerve number 12 is the hypoglossal nerve. Any questions? If you look here, one thing that's labeled on here that we don't have labeled on other things is the trigeminal ganglion. What is a ganglion? Talked about this a couple times. What's a ganglion? It's a ganglion.
I was trying to look it up for you, but it keeps showing me ganglion cysts.
All right, look up, rather than doing it that way, look up ganglion and cranial nerve. What does it bring up then?
It says cranial nerve ganglion is analogous to the dorsal root ganglion,
Yep.
except it is associated with the cranial nerve instead of the spinal nerve.
Okay, so this is the cell bodies of the trigeminal nerve, is the ganglion. So we consider it in the peripheral nervous system, or like the spinal cord, where we call it the peripheral nervous system. The cranial nerves can be considered part of the peripheral nervous system. Why is that the case? Why do we consider them part of the peripheral nervous system? Consider them part of the central nervous system and part of the peripheral nervous system. Why do we, but you notice that we said the brain and the cranial nerves. Why do we consider them part of the peripheral nervous system too? When we talked about the central nervous system, we talked about the spinal cord and the brain. Anything that were outside of those two structures were considered part of the peripheral nervous system. These technically are not in the brain. They're coming out of the brain, but they're not in the brain. So just like the spinal nerves are coming out of the spinal cord, these are coming out of the cranium, the brainstem. That's why ganglion in the cranial nerves has the same definition of that in the peripheral nervous system. It's a bundle or a grouping of cell bodies. And what are the cell bodies in the nervous system? They're the neurosomas. Remember, soma meaning cell body in the nervous system. So going in order, matching from a diagram to a figure, from a diagram to a cadaver. Here's the olfactory bulb. Here's the olfactory nerve, or the olfactory tract. Here's the optic nerve. There's an optic chiasm here. Chiasm meaning to cross, where it actually crosses for the cranial nerve, for all the optic nerve. The information from the right eye is processed on the left side of the brain. Where in the left side of the brain? Where is it happening? What lobe is involved in the visual stuff? Somebody tell me from the other day, where is it happening in the vision for the visual stuff? Somebody go back and look at chapter 14 and tell me, where's it happening for the visual stuff?
I'm looking now.
Okay.
Occipital lobe.
The occipital lobe, right. So it's happening in the occipital lobe. So the information that's brought in through the right eye is being processed in the occipital lobe in the left side of the brain. So it's going to decussate here and cross over. So the oculomotor nerve is the next nerve. The trochlear nerve that's also involved with the eye. We'll talk about that today, here in a few minutes. The trigeminal nerve, right here. The facial nerve, skipped over the abducens nerve, right here. The facial nerve. The vestibulocochlear nerve, which is involved in hearing and balance. The glossopharyngeal nerve. The vagus nerve. The hypoglossal nerve, and the accessory nerve. So looking at a sheep brain that's had almost everything dissected away except for the brain stem and the nerves. Here's the olfactory nerve, the optic nerve, the oculomotor nerve, trochlear nerve, it's also right there, the trigeminal nerve, the abducens nerve, the facial nerve, which is also right there, the vestibulocochlear nerve, the hypoglossal nerve, not hypoglossal, glossopharyngeal nerve, vagus nerve, hypoglossal, and accessory. So your olfactory nerve is your sense of smell. Your optic nerve is your vision. The oculomotor nerve is involved in your pupillary reflex, and it's also called your consensual reflex, is a common. So pupillary is one, consensual is another one. They're both reflexes that have to do with the lens and the iris. Your eye movements, and it's involved in innervating the muscle of your upper eyelid. The trochlear nerve is involved in eye movements. We'll talk about specifically how in a moment. The trigeminal nerve is involved in somatic sensation of the face, the mouth, and the cornea, and muscles of mastication. Mastication meaning to chew. The abducens nerve is eye movement. The facial nerve is muscles of facial expression and taste, and lacrimal and salivary glands. The vestibulocochlear nerve is hearing and balance. The glossopharyngeal nerve is taste and muscle of the pharynx. It also is involved in, has some carotid baroreceptors and your salivary response. When you start salivating in response to something you like, or you go dry mouth because you're stressed. The vagus nerve has autonomic functions. It's involved in slowing down the heart, sensation of the larynx and the pharynx, and muscles of the vocal cords. Also, it has a lot of responsibilities. Spinal accessory nerve is head and neck muscles, so it's only motor. Hypoglossal nerve is movements of the tongue, only motor. So now obviously we have a lot of repetition today. So I'm going to go through and specifically talk about each of the cranial nerves and sometimes show how they relate to the others. Olfaction that involves your cranial nerve 1 is the only sense which has no area in the neocortex. It is only detected mainly in the limbic system. This is why your sense of smell is so highly linked to your emotions and memories. Remember, the limbic system is involved in emotion and learning. I told you about the fact that I don't like coffee, but I love the smell of it because it makes me think of some of my memories of my grandma are related back to the fact that she used to drink coffee, and I learned to love the smell of it because I associated it with her. First order neurons. So the olfactory nerve is made of first order neurons that are the receptor cells in the olfactory mucosa. If you remember, in the very top of the nasal cavity, very superior surface of the nasal cavity, there was a cribriform plate that had cribriform foramina that ran through it, little tiny holes. The fibers of the cranial nerve 1, the olfactory nerve, penetrate this plate and enter into the nasal cavity. How do you get rid of a nasty smell in your nose? Or how do you get rid of a nasty smell that's taken up residence in your head? You blow your nose and you get rid of whatever's in the nasal cavity, and then you don't smell it anymore. Because until you get the chemicals out of your nose that are making you smell something, you're going to keep smelling it because they keep setting off the receptors here. Cranial nerve number 2 enters each of your eyes, and on the very back of your eye that you can see when you shine a light in someone's eyes is the optic disc, which is the place in the eyeball where the optic nerve enters. It's your blind spot too. All the vessels are entering here. All the nerves are entering here. You don't have any visual receptors here either, because it can't all be in one place. You can only put the blood vessels and nerves are not going to be able to all enter at the same place. We're going to have photoreceptors. So you don't have photoreceptors here. But as I said before, the cranial nerves are going to cross, the optic nerves are going to cross at the optic chiasmata. And so your primary visual cortex, like I think Asante said, it was either Asante, I think it's Asante, the iPhone 2. Like she said, your primary visual cortex is, this nerve impulse is going to travel back to the primary visual cortex in the occipital lobe. And then it's going to go to the visual association cortex, which is part in the occipital lobe and part in the temporal lobe. Also, I thought this was an interesting picture. Here's your optic nerve. Comes in through that optic foramen in the base of the skull, entering the eye. Here's some of the muscles of the eye. So in order to understand some of the cranial nerves, you have to be able to understand some of the muscles of the eye. And there are 6 main muscles of the eye. The first one is the inferior rectus. Rectus means that it's straight. It's a straight line. So inferior rectus is below the eye. Lateral rectus is on the side. right here. Medial rectus is on the opposite side, right next to your nasal, your ethmoid bone on that side. Superior rectus is coming on the top. The levator palpebra, palpebra means eyelid. So the levator palpebra superioris is going to be the muscle that lifts up the upper eyelid, elevates the upper eyelid. There's two other muscles. There's a superior oblique and an inferior oblique. The superior oblique is going to come in at an angle. It's going to come in from over here. It's going to go through a little pulley right here, and then it's going to insert here. So I would call it because it's going to come in at an oblique angle. And it's above, so it's superior oblique. The inferior oblique is going to come at an angle from that back side again, go through a pulley and insert on this side of the eye. So we have four rectus muscles: the inferior rectus, the medial rectus, the lateral rectus, and the superior rectus. And then we have the superior oblique and the inferior oblique. All six of these control the eyeball movement. Levator palpebra superioris is going to elevate the upper eyelid. Questions? So cranial nerve number 3, the oculomotor nerve, has two components. It innervates extraocular muscles. Another word for these are extraocular muscles, meaning outside of the eyeball itself. It's going to innervate the extraocular muscles. And it innervates the levator palpebra superioris, the superior rectus, the inferior oblique, the inferior rectus, and the medial rectus. That's not shown here. So I'm going to put that on another thing really quickly here. Actually, no, I'm not, because we'll see it again in a second. It's also involved in the ciliary muscles. What are the ciliary muscles? The ciliary muscles of the eye are the muscles that are behind your iris, that are going to, bear with me here. The ciliary muscles are going to be the ones that are going to affect the shape of the lens. They're what allow you to focus in on an object. When you're nearsighted or farsighted, they're going to be right here and right here, and they are going to change the shape of the lens. And through changing the shape of the lens, you can see things that are really far away and really close. the trochlear lens, the trochlear nerve innervates the superior oblique muscle. It functions in allowing for down and inward movement of the eye, allows you to look down and look to the medial direction. Nope, you know what, I'm wrong. Bear with me just for a second. I thought that muscle won't contract that way. So look, allowing you to look this way. This muscle, when it contracts, it's going to pull here and push this eye to look this direction. So the superior oblique muscle right there. Loss of it will cause you to have an inner movement of the eye looking down like this. I didn't mean to put this slide in here, so we're going to go over this one. It's not meant to be there. The trigeminal nerve has three branches: the ophthalmic, the maxillary, and the mandibular branch. Ophthalmic, what does ophthalmic probably mean?
Eye.
Eye. So, and maxillary meaning your maxilla, and mandibular going towards your mandible. So you've got three branches like this. Sharon for a second here. Got three branches going like this. It's coming off right about right there. And they're going like this: ophthalmic, maxillary, and mandibular. When they go in to do dental work, they're having to anesthetize the mandibular, some branches of the mandibular branch of the trigeminal nerve. It's involved in sensation in the mandibular region, the maxillary region, and the ophthalmic region is your nose, eyes, and your forehead and scalp. So I've told you guys, I've shown you my, I've shown you my panoramic, told you about my opioid overdose. One other experience that I've had with this accident that I was in was I have nerve damage up the side of my face because of probably the way that I hit my steering wheel. I have nerve damage up the side of my face, and it's gotten a lot better. The first year or so, it was pretty awful. I could barely handle letting people touch the side of my face. When I had to work with dentists and orthodontists, I really struggled with them touching that side of my face. But it's gotten better. However, if I get tired now, and if I start getting really nasty allergies and pressure from my sinuses because of my allergies, my face will start to throb. That side of my face will just throb. And in my fun of learning about anatomy, I've learned what's being affected here and what nerve's being affected most likely. I don't have any struggles with motor. Nobody would look at my face and recognize that I have any form of nerve damage whatsoever. However, I struggle with this throbbing every once in a while. And I've learned that if it gets, sometimes it'll get to the point where it's actually bordering on being painful. And I learned really, really long time ago that when it happens, if I lay down on this side of my face, I stop the throbbing. If I lay down on my right side of my face, which is where I hit the car steering wheel, if I lay down like that, I'll stop the throbbing. And initially, when in the first 2 years or so after I wrecked my car, that's what I would ultimately do to get things to not throb, is to just lay down and on that side of my face. And I've learned since then, I learned in my anatomy courses, that the reason that works to stop the throbbing is I'm pinching that nerve. I'm putting pressure on the maxillary branch of that nerve and the part of the mandibular branch. And I'm essentially pinching that nerve and putting pressure on it to get it to stop throbbing, stop with sensation. Moreover, coming off that tangent, coming back to this, the trigeminal is sensory. It's also involved in motor. The mandibular branch is involved in a lot of motor innervating muscles. So it's the masseter muscle, the temporalis, the pterygoids, which we will learn about where these are located the very last week of lab. But the mylohyoid and the anterior belly of the stygastric muscle. It's also involved in the tensor tympani. When we talk about hearing, remember that muscle. Because it's innervated by the trigeminal nerve. How to test it. Brush a patient's face in 6 areas: the forehead, the cheek, the chin, and the patient says what side they feel the sensation on. Ask them to clench their jaw and feel the jaw muscles while observing any weakness. Cranial nerve number 6, the abducens nerve, innervates the lateral rectus muscle of the eye. It enters the eye through that superior orbital fissure in the back of the eye cavity, optic cavity. And the impulses are going to cause abduction of the eye, cause it to look away, look to the side. Look to the side. So just as a summary of the nerves that are innervating the muscles of the eye. Cranial nerve number 3 is going to innervate the superior rectus muscle, the medial rectus muscle, the inferior rectus muscle, and the inferior oblique. The abducens nerve, cranial nerve number 6, is going to innervate the lateral rectus muscle. The superior oblique is going to be innervated by the trochlear nerve. Now, I have a mnemonic for remembering what cranial nerves innervate what cranial muscles. Oh, that wasn't what I meant to do. And it is this. LR6 SO4 AO3. What this means is that the lateral rectus muscle is innervated by cranial nerve number 6. The superior oblique muscle is innervated by cranial nerve number 4. All others are cranial nerve number 3. Remember that mnemonic. It's a great one. LR6, SO4, AO3. Lateral rectus is cranial nerve number 6. SO4 is cranial nerve number 4. And all others are cranial nerve number 3. Any questions? As they're being really quiet. So this is just showing the direction that each of those muscles with the cranial nerves allows you to move the eye. Superior rectus looking up. Inferior oblique looking that way. Medial rectus looking this towards the medial, towards the middle. Lateral rectus looking away. Inferior rectus looking down. Superior oblique looking down like this. Same thing, just a diagram showing the different directions the eye tends to move. Which muscles are involved and which nerves innervate those muscles for the eye to move in a particular direction. Cranial nerve number 7 provides the allows for facial expressions because it's going to act on the muscles. It's going to bring taste to the anterior 2/3 of the tongue. going to be involved in innervating the salivary glands and the tear, nasal, and palatine glands. It produces, when damaged, it produces those sagging facial muscles or disturbed sense of smell. You remember we looked at the Bell's palsy in lecture on Tuesday. That's an inflammation of this nerve, causing that sagging of the side of the face. There's 5 branches coming off it, the temporal branches, the zygomatic branches, the buccal branches, the marginal mandibular, and the cervical branches. Here, just showing on a cadaver image. So it's right below, it's coming off right below the ear. Right there. Any questions? Cranial nerve number 8 is the vestibulocochlear nerve. Fibers that arise from the hearing and equilibrium apparatus of the inner ear. They pass through the internal acoustic meatus, remember acoustic meaning sound, and enter the brainstem at the pons medulla border. There's 2 divisions, the cochlear meaning hearing and vestibular meaning balance. Here's the vestibular nerve, here's the cochlear nerve. It's solely sensory, so it's equilibrium meaning balance and hearing. Cranial nerve number 9, the glossopharyngeal nerve, is involving in swallowing, salivation, gagging, and respiration, breathing. It also provides taste sensations to the posterior third of the tongue. Damage to it can result in a loss of a bitter or sour taste and impaired swallowing because it's involved in the muscles of swallowing. Cranial nerve number 9 is specifically looking at the vagus nerve. So it is the only cranial nerve that its innervation extends beyond the head and neck. So it goes down into the abdominal area. Its fibers emerge from the medulla via the jugular foramen. It's a mixed nerve, meaning it's motor and sensory. And most of its motor fibers are parasympathetic. What does it mean when it's parasympathetic versus sympathetic?
One's fight or flight. That's the sympathetic.
Right. So what's the parasympathetic and opposite, Rachel?
Calming.
It's the calming. So the vagus nerve is specifically more of a calming nerve. So it's going to put out more inhibitory neurotransmitters. It's a calming thing, like Rachel said. Its sensory function is taste. So what 3 cranial nerves are involved in taste? The facial nerve, the glossopharyngeal nerve, and the vagus nerve. Some of these answers that I'm giving you right now, you might see on the lab quest. You might see on the Wiley homework. And you might see them on the case study or this second case study. Cranial nerve 11 is the spinal accessory nerve. So the fibers of the spinal accessory nerve are going to originate off the upper spinal cord and off the nerve itself up here. There's 2 different routes to it. Remember, there's one that's coming off the medulla oblongata and one that's coming off the upper spinal cord. It exits the foramen magnum. Remember that really big hole? The foramen magnum. And it supplies the trapezius muscle and the sternocleidomastoid. SCP. Do they have it here? Sternocleidomastoid. SCM, I'm sorry, SCM, sternocleidomastoid. Meaning that it originates on the sternum and the clavicle, cleido, and inserts on the mastoid process of the skull. And I showed this picture before. One rootlet is coming off the medulla oblongata. One series of roots are coming off the cervical spinal cord. In relationship to all these, here's your trigeminal nerve. Ophthalmic, maxillary, and mandibular. I'm guessing that right here is the facial nerve. But this right here is that's the facial nerve also. This is the glossopharyngeal. This is the vagus, and this is the spinal accessory. Nine. 9, 10, and 11. And if it's moving with the internal jugular vein, it's moving out the jugular foramen. Last one, the hypoglossal nerve. Intrinsic muscles of the tongue. Innervates the intrinsic muscles of the tongue and the extrinsic muscles of the tongue. Hypoglossal meaning under the tongue. So it comes underneath the tongue. So this overview one more time of the sensory, motor, or both. Questions about the cranial nerves? There's two videos I'd like to watch here. One of them is testing of the cranial nerves, and the other one has to do with being able to detect defects in the cranial nerves. If a test comes back negative for the cranial nerves, that's also a test of a defect for it.
This is Sarah, registered nurse, RN.com, and in this video, I'm going to be going over.
Maybe. When she starts up again.
Nursing assessment of the cranial nerves. Cranial nerves 1 through 12. And if you would like to watch a complete head-to-toe nursing assessment, you can access this card up here in the corner or in the YouTube description below to watch that video. So the first thing what you want to do is you want to provide privacy to the patient, perform hand hygiene, and explain what you will be doing. So let's get started. We're going to test the olfactory cranial nerve 1, the sense of smell. So Ben, what I'm going to have you do is I'm going to have you close your eyes and I'm going to put something in front of your nose and have you breathe in and smell, and you tell me what you smell. And whenever you do this, use something that's pleasant smelling, not something that's really stinky, because it could elicit like a gag reflex or something like that if the person has a sensitive nose. Okay.
Vanilla.
Okay, and this was vanilla extract, and that is correct. So that cranial nerve is intact. To test cranial nerve 2, you're going to be doing 2 tests. Number 1, you're going to look at the confrontation visual fields, and you're going to be looking at their peripheral vision. Next, you'll be looking at visual acuity and using a Snellen chart to assess that. First, we're going to test the peripheral vision by doing the confrontation visual field test. And to do that, you're going to have the patient stand in front of you about arm's length away. Okay, then what I'm going to have you do is I'm going to have you cover up your right eye. And I'm also going to cover up my left eye, so on the same side. And Ben, I want you to look at this eye and don't look at my fingers, okay? And I just want you to tell me how many fingers you see. And you're going to do this in the upper and lower visual fields and about the middle of the visual field. So here we go.
Why would this test the cranial nerve number 2? What is it doing? What's cranial nerve number 2 doing?
Isn't it sight?
It is. It's sight.
Correct. Very good. Okay, let's do it on the opposite. Again, stare at this eye, okay? And don't look at my fingers. Very good. Now we're going to test visual acuity using a Snellen chart. And what you're going to do is you're going to have your patient stand about 20 feet from the chart. So Ben, if you'll stand about right there for me, and ask your patient, do you wear glasses? Okay, and if your patient does wear glasses, you'll want them to wear those for this test. Okay, so what we're going to do, look at that chart over there and try to read the lowest line for me that you can read, okay? And first we're going to cover your right eye, then your left eye, and then we'll do both eyes. Okay, so cover your right eye. Okay, and what line can you read? Okay, read it for me. Okay, very good. Okay, now we're going to cover up your left eye, do the same thing. And again, whatever line you can read, let me know. 8 again, okay. Okay, and now read with both eyes. And what line? Okay. Okay, and he read from line 8, so that means that he has 20/20 vision. And this means that he can see the same line of letters at 20 feet that a person with normal vision can see at 20 feet. However, let's say that in his left eye, he could only read like line 6, which is 20/30. That would mean that his left eye sees at 20 feet that a person with normal vision would see at 30. Next, what we're going to do is we're going to assess cranial nerve 3, which is ocular motor, 4, trochlear, and then 6, which is abducens. And we're going to do several tests to check their function. The first one, what we're going to do is we're going to be looking.
What is their basic function? All three of those, what do they do? Generally, what do they do? Generally, what is their function, all three of them?
Isn't it like eye movement?
It is, it's eye movement.
Looking for any involuntary shaking of the eye called nystagmus. And how we're going to do that is we're going to take our pen line. We're going to hold it about 12 to 14 inches away from the patient's nose. And Ben, what I want you to do is keep your head still. Don't move your head and just use your eyes to watch where I move the pen line. And as you're doing this, you're going to perform it in the 6 cardinal fields of gaze. And just going to move it, and you're looking for any involuntary shaking of the eyes. So here we go. Next, we're going to see how reactive the pupils are to light. And to do that, we're going to dim the lights a little bit, and we're going to have the patient stare off at a distant object that helps dilate those pupils. And then we're going to shine using our pen light in at the side, and we're going to see how that pupil responds. It should constrict, and then on the other side, it should constrict as well. So say their baseline pupil size was like 3 millimeters, it should go down to 1 millimeter, and it should happen on both sides. Okay, so Ben, stare off at that object right on the wall over there for me. Okay, and that dilates the pupils, and we're just going to shine light in at the side. Okay, constrict, constrict. Okay, dilate again, and then go over to the other side. Do the same again, and they both constricted and equal size. Next, what we're going to do is we're going to check for accommodation. And how we do that is we turn the lights back on. We just previously had them dim, but we now make it light again. We're going to have him stare off at a distant object that helps dilate the pupils. And we're going to take a pen light. You can use a pen light finger, and you're just going to slowly move it inward to the nose. And what you're looking for is that those pupils constrict, they accommodate, and the eyes cross while looking at the pen light. So here we go. Stare off in the distance, please. And I don't want you to move your head or anything. Just keep it real still and just follow this pen light, okay? Ready? Okay. So now we can document, because we just checked all of the things with the eyes, we can document that the pupils are equal, round, reactive to light, and accommodate. So that's where that acronym PERRLA comes into play. We're going to go ahead and test cranial nerve 5, which is the trigeminal nerve. And this nerve is responsible for many things like mastication. So what I'm going to have you do, Ben, is I'm going to have you clench your teeth, like bite down, for me. And I'm going to feel the masseter muscle, which is right there. It should be a nice firm ball. And then feel the temporal muscle. Now what I'm going to do to also test that nerve is have him try to open his mouth against resistance. So try to do that for me. Okay, and he can do that. And while we're here, we're going to go ahead and look at the facial expressions and test cranial nerve 7, which is the facial nerve. So can you close your eyes tightly for me and open them up? Okay, now smile for me, frown, and puff out your cheeks. Okay, and he did that with ease, so that cranial nerve is intact. Next, we're going to test cranial nerve 8, which is the vestibulocochlear nerve. And what I'm going to do is I'm going to include one of his ears and then whisper 2 words on the other side. He needs to tell me what I said. So, you ready? Okay, I'm going to include this one. Okay, very good. Okay, and that nerve is intact. Next, what we're going to do is we're going to assess cranial nerve 9, the glossopharyngeal. So what I'm going to do is I'm going to have you say ah, and what you want is that uvula to move up. Okay, and then we're just going to test the gag reflex. I'm sort of just going to poke a little bit back there and elicit the gag reflex. Okay, there you go. That's really good. And cranial nerve 10, the vagus is intact because he's able to talk to me without hoarseness, and he's able to swallow. Then what we're going to do is we're going to test cranial nerve 11, which is the accessory nerve. So Ben, what I'm going to have you do is move your head side to side, up and down. Okay, and then shrug, try to shrug against my resistance. And he does that with ease, so that nerve is intact. Next, what we're going to do is we're going to assess cranial nerve 12, which is the hypoglossal nerve. And what I'm going to have you do, Ben, is I'm going to have you stick out your tongue and move it side to side. Okay, and he does that with ease. Okay, so that wraps up how to perform a nursing assessment of the cranial nerves. And don't forget to check out that head-to-toe nursing assessment video. Thank you so much.
One more, a little shorter.
Hello everyone, welcome to Scario.com. I'm Dr. Hina Khan, and today we're going to discuss a very significant and quite interesting topic relating to the cranial nerve pathologies. So you would come across these patients who are being affected by these cranial nerve pathologies, and we have basically these 12 pair of cranial nerves that we'll be discussing over here in this particular lecture. So the outline of this lecture basically consists of the underlying pathologies of these cranial nerve disorders. What are the set of clinical features that you're going to observe in these patients? What are the diagnosing factors, the differential diagnosis, and further on the treatment modalities that are present out there to give the correction to such cranial nerve disorders. So we'll be discussing the set of signs and symptoms that the patient would usually come up to you with. Usually pain and numbness is the key feature. Then we can come across patients who complain of facial weaknesses, and we'll be going through the specific most common condition, for instance, Bell's palsy as well over here. Then we have the facial pain and numbness. So it's very important that you have a differential diagnosis in your mind whenever you have these patients of facial pain and numbness at your hand. Trigeminal neuralgias would be discussed over here, the definition, the causative factors, the risk factors, and along with that, how does it develop over the period of time would be discussed in this particular lecture. We have 4 major groups of underlying pathologies that would be discussed, and basically they are all resulting in the trigeminal nerve disorders, particularly over here. So the special features would consist of the nuclear lesions involving the tumorous conditions as well as the particular infectious states in this kind of condition. Then a lot of preganglionic conditions, for instance, acoustic neuromas, meningiomas, and METs would be also traveling through distant organs to this particular central nervous system and affecting the trigeminal nerve. Then we have the Gasserian ganglion lesions that are particularly discussed over here. We'll be discussing the peripheral nerve lesions, the different syndromic conditions, for instance, the Guillain-Barré, the Georgian syndrome, and a lot of traumatic and infectious states that can result in the development of these trigeminal nerve disorders would be discussed over here. Bell's palsy, a very common condition, the definition, clinical signs and symptomatologies. We'd be discussing the common conditions such as blepharospasm and also the cranial nerve syndromes along with the sites which can basically, if they are traumatized, if there is a tumor occurring in these sites, it can basically affect the particular cranial nerves that is the site is accommodating. So we'll be discussing these sites in detail as well over here. Then a lot of palsies are discussed in detail over here. So basically you can watch this lecture as well as a variety of other lectures on.
Okay, I should have looked at that one completely because it seems like it's an advertisement on it for a lecture, and we're not going to do that. Do you have any questions about the cranial nerves? No?
No.
Okay. Let's take 10 minutes. I want to come back and the special senses chapter, I'm gonna reverse chapters. We're gonna do the special senses first. And then we will work on it and finish it next Tuesday and do the autonomic nervous system next Tuesday also. You'll see these aren't very long chapters. But let's come back in like 10 minutes. You ready to go out? You wanna go outside? Maybe. And then it came on just as I was starting to fall asleep, but I thought I could get up and do it. I could get up and deal. And I'm like, no, I'm tired. I'm going to bed. Just use that by itself right now. What? You're just causing chaos for you. All right. Yes, they're up on top. Come on, Paisley, Paisley, come on, here she comes. I don't know if you remember or if you feel as brain dead as I do this morning, that I said that I wanted to do a brain dissection with you. And then I got preoccupied with the lecture and thought about that. And then I realized as I was going to break that I really did want to do a dissection with you. So I have here, need one more thing. I apologize. I have a sheep brain. And you can buy these from a company in North Carolina. And the first thing you want to do anytime,
Should have asked you this before you get all gooey, but can you make your screen so we can see you bigger?
I don't know if I can.
Oh,
How would I do that? Do you know?
I don't know. I was just like, cause like when you like, sometimes I can see you on the big
You can't
screen, but
see
you're like in a
me.
little box.
Oh, I'm
You
in a
just
little
have to
box.
stop sharing your
Oh,
screen.
oh yeah. I apologize. Give me a second. I kept wondering why it was so strange. Give me a moment. I'm sorry. I'm having a little bit of a brain dead stupor this morning. I think I'm relating it to the fact that we had a power outage here last night. And so I just, it kind of knocking me off kilter here. Do you see now? Do you have a big screen now?
Yes, thank you.
Awesome.
I just want to say
Yeah.
that me and you match, Mary. Hold on, I'm about to show you my camera. We both got our gray jackets and our glasses.
Oh, isn't that cool? We planned it, didn't we? We planned it.
I'm done. I just happened to look. I was like, oh, we both got our gray
That's
jackets
awesome. We
on.
planned it that way. You know we did.
And it has the white strings.
Awesome, awesome, awesome. Okay. So looking at this, I'm still getting it out of the packaging, obviously. The first thing you want to do anytime that you're looking at an organ, and this is actually a really, really cleaned up organ. They're not always this cleaned up. But anytime that you're looking at an organ, you want to orient yourself and start figuring out, just looking at the surface, what you can see and what you can't see. And right here is the brain. She's on the chair here. Here's the brain stem. And actually, if you look here, it's really kind of small. But you can see the cross section of the spinal cord. Can you see that?
Can you lift it up just a tad bit? There you go. Thank you.
Can you see it? You
Yes.
see the cross section? Right here's the medulla of the cerebellum. If you look, you can see the individual folds of it. The folia in there. Turning it over, you see the two little lines that are running down the front here? Two little regions that are running down the front here.
Yeah.
That's the medulla oblongata. Let me just for a second here. Trying to see if I can see anything else here. Oh, you know what? I'm just removing a little bit of what is it? I would say that's probably dura mater, but it seems like it's really quite thin, so maybe more pia mater, because dura mater tends to be really, really tough. But right in there, they're really, 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 really tiny. But I think I see the mammillary bodies. They would be right here and right here. So here's the medulla oblongata. Here's the medulla oblongata. Here's the pons. Here's the brainstem. Right here is the midbrain. Sorry. I flip it over, and I don't know how well you can see it, but there's a bump right there, there's a bump right there, there's a bump right there, and there's a bump right there. We're looking on the posterior surface right underneath the cerebellum. Do you remember what those are where there's a set of 4 bumps? What was it when there was a set of 4 bumps? The corpora quadrumina. The top ones are the superior colliculi. The bottom ones are the inferior colliculi. Remember, the top ones are involved in visual reflexes. When you can track an item, even as you're moving or it's moving. And your ability, your startle reflex, where you hear a loud noise and you turn towards it. That's your inferior colliculi. Right here is the very top part of the optic chiasm. And we go off like this and off like this. Any questions so far?
No.
So if the dura mater was here, and we don't have dura mater here. If the dura mater was here, it would from the tentorium cerebelli that would be around here. It would from the false cerebri, which would separate, false cerebelli that would separate the 2 hemispheres of the cerebellum. And in here, in the longitudinal fissure right here, we would see the false cerebri. And the superior sagittal sinus would be on the anterior, the superior surface of that. Now I'm going to make some more cuts here. Actually, let me do a little bit more here. The frontal lobe, the parietal lobe, the occipital lobe, and the temporal lobe. We're gonna just remove this section right here. Let's see here. So looking right here, if you look right here, you see that it's very white. That's part of the corpus callosum. It's coming down like this, over like this. If you look here, there's a little indentation moving in right out right there. You see where there's an opening? I haven't made any cuts there. That's the opening into one of the lateral ventricles. Down here, you see where that it tends to look a lot darker right there? That's the fourth ventricle. Why does it look so dark there? Why does it look so dark? What was it? What happens in the fourth ventricle? What happens in all the ventricles? What is found in the ventricles?
Is it blood?
It's not blood. What we're seeing there is kind of blood, but why do we see blood there? Why do we see blood there? What's flowing through the ventricles? It's not blood. It's made from the blood, but it's not blood.
Cerebral spinal fluid?
Yep, cerebral spinal fluid. So remember how the cerebral spinal fluid is formed? It's formed from the choroid plexus, which are those specialized vessels that secrete cerebral spinal fluid. And that's what that is, that dark. I'll do one other cut here. If you look here, do you see the white and the gray matter?
It's kind of hard to tell because it's so dark.
Mom, can you grab me an extra lamp? And help me plug it in. I would bring it right over here. It's still kind of dark, but we're going to see if we get more light, if it will help.
I think if you close the blinds, it'll probably work better. It's the backlighting that's making it dark where you are.
Does that help?
It made it a little bit brighter.
Do we have an extension cord, Mom? Now, because my hands are all gooky, I'm not gonna touch it. Thank you. That would be kind of nasty. This one might be best.
We'll put them both on.
Is that better?
Is that good and not glaring?
Is that better?
Yes.
Yeah.
Okay.
Yeah.
So can you see, looking at this, can you see the white and the gray matter? It's still kind of dark, I know.
It kind of looks like the white matters in the middle, and then the gray matters like outside on the.
It is. It is. One other thing, when we put these two back together, let me see here. Sure, put them back together right. Right here, this little indentation here where I actually cut down, that's a septum pellucidum. Here's the one lateral ventricle. Here's the other one. And you can see the white matter, how it's moving out. Remember how it connects the different parts of the cerebral cortex and the spinal cord down below. I want to do one other thing while we're playing with this. Here's the cerebellum. I'm going to cut it in half. I'm trying to make it as clean a cut as I can. Maybe a little better cut. Which one is better? This one is reasonably better. If you look right there, right in the center, do you see the white? How it's spanning out? Yeah. What is that white spanning out? You can see that you saw the white matter in the cerebrum. What is that that's spanning out there in the cerebellum? And I'm sorry, my hands are shaking. What is that? We're looking at a cross section through the cerebellum. What is that? What did we find in the center of the cerebellum? Do you remember the arbor vitae? That tree of life that's all white matter spanning out the throughout the cerebellum. Also looking about right there. Here's the medulla oblongata. The pons right here. Medulla oblongata, pons right here. Right, about right here, right in this little area right there, would be the fourth ventricle. Questions about any of it? Is there something you want to see that I may or may not be able to get to? I opened up the lateral ventricle here on this side a little better. Right there. You can see the gyri and the sulci. Remember, the gyri are the upper folds, the sulci are the lower folds, are the indentations of those folds. Questions? All right, let me clean this up and let's spend a little while starting on the special senses. I was told just to focus on one special sense that I know fairly well. And I chose hearing and balance because I definitely know the most about those. And so I'm going to clean this up really quickly. And then I'll start that. So give me just a few minutes here. Can you grab me a plastic bag? No, one of the little tiny ones, not one of the tiny ones. It doesn't have to be very good. Probably if it has any holes in it, we'll be sorry because it's gonna have brain parts. Sandwich size. We don't want to have little brain parts working out. A sec. A sec.
I'm looking around for my glasses. I took them off and I put them back on my face. Mary, your mother's a bitch.
Oh, no, I understand that.
Been there, done that. Next time I get brains from that can come into the devil. All right, you want me to be out of there? I can find something. Maybe 12. I'm finally getting my breakfast. All I am getting from breakfast.
Okay, so let's start talking about the special senses, hearing and balance. And I don't think I have a quiz up for this or a practice, but I will get it up. Or I think I have the smart work assignment posted, but I don't have the rest of it, so I'll get it up. So going a little bit out of order, but let's do the special senses because we just talked about the cranial nerves. Do you remember what cranial nerve was involved in hearing? What cranial nerve is involved in hearing?
I can't say it.
What does it start with?
It's number 8.
Yep, it is. It's a vestibulocochlear nerve.
Yeah, I wasn't even gonna try.
So the special senses, specifically looking at hearing. So a summary of hearing. The sound waves are focused by the pinna, meaning the outer ear, and then they enter the ear canal. The eardrum then vibrates. We call it also the tympanic membrane. This vibrations of the tympanic membrane are passed on to the anvil, which is also called the malleolus, the hammer, and the stapes. We call the words here are not, we call them the, let's see here, the incus, the malleolus, the incus, and the stapes. But the 3 little bones, the ossicles within the ear. In the cochlea, those vibrations that are passed from the tympanic membrane through the ossicles then are going to vibrate a window that's going to lead into the cochlea. The cochlea is really your organ for hearing. This is just conduction of the sound. The cochlea is your organ for hearing. The auditory nerve that's attached to the cochlea, remember the vestibulocochlear nerve is 2 nerves, the cochlear nerve and the vestibular nerve. The cochlear nerve is also your auditory, is also the auditory nerve. So the auditory nerve is going to pass the electrical impulses into the brain. The semicircular canals are for balance, and they are going to be innervated by the second nerve of the vestibulocochlear nerve, the vestibular nerve. Any questions so far? What is sound? Sound is any audible vibration of molecules. If you think light moves in wavelengths, sound does too. If you've ever been to a rock concert or a concert of any kind and saw the speakers up on stage, how they sit there and they vibrate, they're vibrating because of the wavelengths of sound. And they're vibrating in accordance with the wavelengths of sound. So they're pushing it out and it's creating these wavelengths moving out. So a vibrating object is going to push on the air molecules in front of it, creating this vibration of sound. The peaks or the amplitudes of the waves are the higher pressure. The lower parts of the waves are the lower pressure. So this higher pressure, lower pressure waving of the sound air molecules are going to result in the tympanic membrane vibrating at the same wavelength and moving in response to the wavelength, the sound waves. Pitch is the characteristics of sound. Is it a high sound? Is it a low sound? It's determined by the frequency, meaning the cycle of the vibrations per second, which is measured in hertz. The more vibrations you have per second, the higher the pitch. Loudness is the perception of the intensity or the amplitude of the vibration. How much air is being compressed? And this is measured in decibels. Just as a not one more way to look at this. The high, this area, this area, this area, this area are referring to these high pressure moments. Actually, I think I'm saying that wrong. These are the high pressure moments. These are the low pressure moments. So high to low, high to low, high to low, high to low. The human hearing range is 20 to 20,000 hertz. Here's hertz along here. 20, right to 20,000. Speech occurs between 1,500 to 5,000 hertz. Most hearing losses with age, meaning nerve issues, is in the range of 250 hertz to 2,000 hertz, which if you look here is right in the speech pattern. Normal conversation, with regards to loudness, normal conversation is about 60 decibels. And the pain threshold, where sound becomes painful, is 120 to 40, 140, 120 to 140. A prolonged exposure to more than 90 decibels. Prolonged exposure to more than 90 decibels, approximately right here, can cause damage. Any questions so far? There's three basic sections to the ear: the outer ear, the middle ear, and the inner ear. The outer ear includes the pinna, the auricle here. The auditory canal. What is that bone called that makes up your auditory canal? What's that bony marking called that's right here? Somebody tell me. What's the bony marking that makes up your auditory or your ear canal? It's your external acoustic meatus. Here's your tympanic membrane, which we also call your eardrum, but in science terms, it's your tympanic membrane, your malleus, your incus, and your stapes, the three little ossicles. Once we pass the tympanic membrane, we're now in the middle ear. The boundary between the middle and outer ear is the tympanic membrane. The middle ear includes the three ossicles that are within the tympanic cavity. The inner ear is the cochlea, this organ of hearing. The nerve, you see the two separate nerves, the cochlear nerve coming out to the cochlea, the vestibular nerve coming out to the semicircular canals. The malleus is going to attach onto the tympanic membrane. And the stapes is going to be attached to the oval window that's attached to the cochlea. Cochlea meaning like a shell, because it looks like a curled shell. So the outer ear and the middle ear are involved in the transmission or the conduction of sound vibrations. The inner ear is the conversion of those vibrations to nerve signals. The outer ear, also called the auricle, is going to direct the sound waves into the ear. The external auditory canal, or meatus, has within it, it has caruminous sebaceous glands that with dead skin cells are going to produce carumen. Carumen is the scientific physiological word for earwax. Cerumen, as my mother's correcting my pronunciation, cerumen. I did not know that. Cerumen. With the guard cells, the cerumen, there's guard cells also within here. The guard cells, it's going to protect the outer end of the canal. Now, I've told you I'm hearing impaired. And I don't wear it when I teach this class. I wear it when I teach my face-to-face classes, because I wear a hearing aid and I don't wear it when I teach these classes. I teach it for my face-to-face classes. With these classes, it's more a distraction to me because it amplifies a lot of sounds. And with so much sound going on in my house and out on the street, I do better if I'm not wearing it. I get easily distracted. But this little hearing aid that I wear actually inserts right into my ear canal. And one thing that I've learned from experience with these little in the ear, completely in the canal ear hearing aids, is your earwax, or your cerumen, as my mother told me it's pronounced, is an immune response. If you've ever smelled earwax, you'll never forget what it smells like. It's nasty. It stinks. Why does it stink? Because it prevents things from taking up residence in your ears. That's the reason it stinks so bad. With my little hearing aid, the fact that it's completely in the canal, and it's all, as often as I wear it, my ear thinks that there's something trying to take up residence in my ear. And as a result, I produce a lot of earwax. And then I clean it out regularly, because my ear is creating an immune response against my hearing aid, so that my hearing aid doesn't take up residence in my ear. So the more you have something that close to your ear, the more earwax you're going to produce. The tympanic membrane is going to vibrate to the same wavelengths as the sound waves that enter the ear. Within the middle ear, once we pass the tympanic membrane, we're now in the middle ear. It contains the ossicles, these very, very small bones that also distinguish you as a mammal from other animals. All mammals have these ossicles. Are these small bones that are going to amplify the sound waves and transmit the sounds to the inner ear. The first one is the malleus, the hammer. It's connected. It actually has an attachment on the tympanic membrane. And it is going to vibrate freely in response to the tympanic membrane that it's attached to. Tympanic membrane is innervated by the vagus and the trigeminal nerves and is highly sensitive to pain. That's why rupturing of your eardrum hurts so bad. The incus, or the anvil, and then the stapes, which has a little foot plate. You can't see it really well here. It's right here. Has a little foot plate that connects to the oval window of the cochlea. One also thing that we have is a connection that is going to leave via the middle ear and connect with the inner nose cavity, the posterior nose part of your nose, actually not even your nose, your nasopharynx, which is the part of your throat behind your posterior nasal cavity, is your auditory or eustachian tube. This little space is a very small, reasonably hollow space. And there's the eustachian tube is going to connect up with the pharynx in the back of your throat, back of your nose, nasal cavity. Swallowing or yawning will allow you to equalize the pressure. Have you ever changed altitudes and had your ears pop?
Yes.
What that is doing is the atmospheric pressure and the pressure within your middle ear are equalizing. Initially, when you change altitudes, your middle ear is still at the altitude that you were at prior. And that popping allows you to equalize that pressure. I can tell you from experience, people who struggle with any nose issues will struggle with ear issues too. Well, not all, but many of us. And the reason I share that with you is I cannot equalize the pressure in my ears very easily. Can't equalize that pressure in my middle ears by yawning or swallowing to open up that eustachian tube. When I fly, I've gotten in a habit of when I fly, I prophylactically take Tylenol or ibuprofen or something, because I know that I'm not going to be able to equalize that pressure, and I know that it's going to hurt. And so I will, before I even get on the plane, or about the same time I'm on the, as soon as I, how do I put it? As soon as I'm either I'm sitting down on the plane or middle of the plane ride, when I realize, depending on the length of the trip, I will take Tylenol, because I know that when we change altitudes and when we go down in altitude, my ears will not equalize as easily as they should. And it causes an exceptional amount of pain. And if you look, like it said here, your tympanic membrane is highly innervated. What you're feeling is the pressure within there that's causing the pain. Pressure in the middle ear. This tube is normally flat. You have to open it up to allow the equalization of the pressure. You do that by yawning or swallowing. I know, because I have a good friend who, I told you that it tends to be linked to nose issues. I have a good friend who got the tip of her nose torn off on a trampoline accident. So she somehow got her nose caught in the springs of the trampoline. And she will tell you that it honestly didn't even hurt. She said she just, she was just covered in blood, but it didn't really hurt. But we were talking one day about this equalizing pressure here and how this would work. And mine will eventually equalize out. It may take hours, and it may be hours after I get to wherever I was going, but they will equalize out. Well, hers will actually crack and bleed. Her ears will start to bleed. What I think is occurring is that the membrane is rupturing. Her tympanic membrane is rupturing, as my mom is nodding, because she can't equalize that pressure. So I realized when she told me this story that I had nothing to talk about, because obviously my issues are nothing in comparison to hers, because mine have never bled. One last part of this, and then we'll stop here. And this feeling of having an unequalized pressure in your ears is similar to having a middle ear infection. Rather than having it be an air pressure, it's a fluid pressure. Middle ear infections are common in children. If you look here, the auditory tube that would drain fluid from your middle ear is horizontal in children, and it's short. In adults, as your face elongates, it takes on a more vertical direction, allowing fluid to drain easier. And infections can easily spread from the throat to the tympanic cavity via that same this eustachian tube. The fluid accumulates in the tympanic cavity, causing pressure and pain and impaired hearing. I know that when I have a cold, I thought my hearing was bad before it gets much worse because of the fluid buildup. It can spread, leading to meningitis. Another thing, chronic ear infections can cause the fusion of the ear ossicles, or what they call otosclerosis, which is what I have now, at least in one of my ears. Bones enlarge, and then they don't go back to their original size always, and they fuse. And you know what? Let's end right here. I will see you next Tuesday. We will finish this and start or finish most of the autonomic nervous system. Have a wonderful day, okay? Miranda,
Yes.
I will extend that out for you right now.
Okay. Thank you.
You're welcome. Catherine, Maldonado, Courtney, or Jamie, are you still here? Okay, I'm gonna end the meeting.